So I've already introduced Dr. Zay a little bit, but it's my pleasure to introduce Dr. Herbert Zay. Dr. Zay, since 2018, has served as the professor and chair of the Department of Surgery at the UT Southwestern Medical Center and holds the Hall and Mary Lucille Shannon Distinguished Chair in Surgery. Dr. Zay earned his medical degree at the University of Pittsburgh School of Medicine. He completed his surgery residency and fellowship in advanced GI surgery and surgical oncology at Johns Hopkins, where we got to know each other. Prior to joining UT Southwestern in 2018, Dr. Zay served as the Watson Family Professor of Surgery at the University of Pittsburgh School of Medicine, the chief of the Division of Gastrointestinal Surgical Oncology at UPMC Hillman Cancer Center, and the co-director of the UPMC Pancreatic Cancer Center. I've had the good fortune of knowing Herb and training with Herb and being his friend since our times together at Hopkins. In 2011, Herb and I ran the Pittsburgh Marathon together. He actually wanted to run it, but it was this past weekend, so he gave that up to give the camera an oration. And I promised him we'd run a marathon together in 2026. Dr. Zay recently came to the University of Arizona to give grand rounds. During his talk, he quoted Wayne Gretzky, who said, "A good hockey player plays where the puck is. A great hockey player plays where the puck is going to be." Dr. Zay's surgical career truly embodies this quote. He is an innovator and a leader in the field of pancreatic diseases and pancreatic cancer. Dr. Zay has conducted numerous investigator-initiated clinical trials examining novel treatments for patients with pancreatic cancer. He directs a translational research lab and is a co-investigator on 3 R01s. He's authored more than 450 peer-reviewed publications and 20 book chapters. Dr. Zay and his colleagues have accumulated research and published extensively on one of the world's largest experiences with robotic pancreatic surgery. But not only did his team achieve excellent outcomes, they developed reproducible methodology for teaching others, both experienced surgeons and residents, to do the same, reducing the learning curve and making minimally invasive pancreatic surgery more accessible even to people like me. He's doing some pioneering work on improving safety in the operating room through simulation and operating room black box. And he's always moving to where the puck will be and is defining the future of pancreatic surgery and surgical safety. Without further ado, Dr. Zay.
Well, thank you. When Taylor asked me to give this talk, of course, I was incredibly honored, but she didn't tell me that I would have to follow that. So that was an amazing exploration, and thank you for sharing all of that with us. I am very honored to give this talk today. What Taylor didn't tell you about the marathon in 2011 is that she finished, went upstairs, took a shower, had lunch, saw a movie, and then came down and met me at the finish line. So that's how the story goes. All right, let me just, where's the advancer here?
You're gonna once click on this, and then after that you can use the arrows. No, just once.
All right.
I don't know why it's stupid.
Okay. I just have one disclosure. I am on the Scientific Advisory Board of the SST, and I'll very briefly talk a little bit about the black box, not a whole lot. So I am very honored to give the Doris and John Cameron oration, and every talk tells a story, and my story starts with Dr. Cameron, obviously one of the giants in our field. And some of this is legend, and you got to be careful what you believe, but during my ACS year, there was a snafu in the scheduling, and one of the fellow ACSs, where we were supposed to be on every other night call and operate with Dr. Cameron, had to be off for a while. And the story goes that Dr. Lillimo went to Dr. Cameron and asked, well, what are we going to do? We'll have to have one of the faculty take call. And Dr. Cameron said, no, I think Herb can take it. So I did for about 6 months of every night call. And I also, as a result, got to operate with Dr. Cameron every day. And so that was a pretty amazing experience. And it was during one of these prolonged experiences when Dr. Cameron was getting, I think, close to about 1,500 Whipples. And I remember asking him, Dr. Cameron, how many do you think you're going to do in your career? And he said, I don't know, maybe 2,000. and I had very low EQ. I quickly blurted out, well, I'm going to do 2001. So, but it was that experience where I started thinking, maybe there's something more. And then as I got out of residency and fellowship and went back to Pittsburgh and started thinking about, well, what would be my contribution to pancreatic cancer surgery? It wasn't going to be 2001 Whipples. It really started saying, well, where can we make a difference? And this paper from another Hopkins resident, Jordan Winter, came out not too long after that. And it was pretty sobering for us in this field, right? So Jordan looked at 3 decades of outcomes at Memorial Sloan Kettering from the Whipple procedure for pancreas cancer. And sure enough, we had improved 30-day mortality. We had improved 90-day mortality, 1-year mortality. But the sobering thing was that the outcomes, the cancer outcomes, the disease surviving was actually the worst in the last decade, even despite these improvements. And so that was really, as I went to Pittsburgh, the home of Bernie Fisher, sort of the first dilemma. There was obviously competing paradigms. Was cancer a systemic disease at the time of diagnosis and required something other than surgery, or was more radical surgery going to really help us get there? And there was another hint about where to go with this. Another paper published out of Hopkins by Matt Weiss, where he looked at all these open Whipples, and only 54% of the patients actually went on to get their adjuvant chemotherapy, and arguably the best place to get your Whipple in the United States. And so if cancer is a systemic disease and patients need chemotherapy, I started to think, well, what can we do to make a difference? How can we start to attack this as a surgeon to make a difference? And it was pretty straightforward. Surgeons aren't deep thinkers. We could either change the sequence of treatments, meaning give chemotherapy first, or we could make surgery less morbid so that they didn't have complications and they'd go on and get their chemotherapy. And we tried to do both in Pittsburgh. The first topic is a whole nother talk, and I'm not going to get to that today. But what I really want to focus on is this idea of making surgery less morbid. So it's obvious that MIS has the potential to decrease morbidity. We could take an operation with a big open incision that takes 6 or 8 weeks to recover. And the thought was, well, maybe we can use a technology, an MIS technology, and make it less complicated and get the patients to chemotherapy, less complications. And when we started thinking about, well, which of these surgical instruments for MIS are out there, it was obvious that really most of the history of surgical instrumentation was small modifications. They were still really just the human motor cortex controlling the hand. Even laparoscopy, it's still the human motor cortex controlling the instrument just at the end of a chopstick in 2 dimensions. And I didn't think any of those were really sufficiently advanced enough to spend a lot of time. And so we made the decision to focus on robotics, mostly because what I saw was this is the first time we put a computer between the patient and the surgeon. And there we can really start to make a difference. We can start to augment human skills. And certainly in the airline industry, that's the case, right? So this is a World War II fighter jet, the cockpit. The pilot controlled the plane from a yoke where he turned the flaps and fired the arms. But now you could not fly a modern jet without a computer helping you. You really, in order to process all that information, you have to have a computer. And so computer enhances human skills. And for that reason, we made the decision to really focus on the robotic platform and to really see what we could do to apply it to pancreas surgery, and with the idea being to minimize complications and get them to their chemotherapy. So we set about that 2008, and this is a list of the many people who have contributed to that experience. And since 2008, we've done an enormous number of these cases. Really, I put this up there not so much to brag about how many Whipples, because you can always, it's never the real number of Whipples. But really, 2 points. One is that when we adopted the robotic platform, we really started doing every operation that we were doing open with the robot. So there really wasn't a pancreas case where we said, oh, well, we still have to do that open, with the exception early on of some of the vein resections, but we've passed that threshold now. So as this, what I'd like to share with you today is a little bit about, this pathway and this journey that we've been on since 2008. I'll speak very quickly about safety and feasibility, which was really early on. Could we do this with the same low mortality? Because certainly taking a step back and having high mortality wasn't going to help us. I'll talk a little bit about the optimization and when we really felt like we had a procedure that was close to what we were doing open. And then, as Taylor already alluded to, we really made a conscious decision to focus on dissemination. And I remember early on, they used to invite Mike Kendricks and I to these international meetings and try to pit us against each other of laparoscopic versus robotic. And over breakfast one day, I said, really, it's going to be legacy and it's going to be posterity that decides which of these platforms. And it's not going to be what you do or I do. It's whether we can teach it to others. And so we made a conscious decision not to do a randomized trial, although that's been done now, and I'll talk about that. But we really said, if we're going to make this something that's going to help a lot of patients, we got to figure out how to teach it to people in a way that's meaningful and enduring. So safety and feasibility were the usual. We published our first 25 cases. Jim Mosier was really instrumental in this early time. Jim, a Princeton mathematics major, very precise, methodical, was a nice counterfoil to a little bit of my premature cowboy. I wasn't a cowboy then. I was in Pittsburgh. Now I'm in Dallas. And so it was for us to develop this together. I would usually want to shoot first, ask questions later, and Jim wanted to take it a little bit more. And so but we were able to get through the first 50 and the first 250 and really show that we were not seeing increased mortality or any major complications that should caution us to slow down or to stop. Eventually, Amr Zurikat published our first 500 cases of robotic Whipple, and you can see there how long it took us to get to those. If you look at OR time over the first 500 Whipples, blood loss, and median length of stay, they all continued to improve. And eventually, we got to what we thought was a pretty good, mature robotic pancreaticoduodenectomy, and the mean time was around 340 minutes. Grade BC fistula rate about 10%. Conversion was 3%. Reoperation 1.5%, and mortality 30 and 90 days were very equivalent to large open series. Length of stay around 7 days and equivalent surrogate oncologic time points. So if you compare that to what Dr. Cameron was able to do, this is from his 2,000 consecutive pancreaticoduodenectomies. If you just use OR time as a surrogate for proficiency, you can see that there was also a very rapid improvement from 1970 to 1980 over about 10 years. But we were able to accelerate that, we feel like, that learning curve and really obtain, it won't let me go back. There we go. And obtain proficiency in a shorter period of time, probably over about 2 or 3 years before we reached that. But there was a sobering, as I showed you, 500 cases. It was a little bit sobering when we asked Brian Boone, who was one of our residents at that time, to say, okay, well, really, what is the learning curve for this? Go through both the robotic Whipple and the robotic distal and figure out, how many cases did it take us to get to proficiency? And we used OR time because I think that's honestly the best marker for OR proficiency. And Brian was able to show that it was really 80 cases for the robotic Whipple and 40 for the robotic distal. And that's actually not too far away from some of the people in this audience who have published on the open pancreaticoduodenectomy learning curve, which was estimated to be around 50 or 60 cases for open. Nevertheless, that is a daunting number of learning curve cases. If one considers that the average general surgery resident in this country finishes with a median of 0 Whipples, and the average surgical oncology fellow only finishes with a median of about 10. So you're talking about unsurmountable learning curves. And so we really started to worry. It's like, how are we going to figure this out? And that's the next part of the story that was a bit of serendipity, where Dr. Melissa Hoag comes in. The story goes that at that time, Dr. Zurikat and I were doing most of the robotic Whipples together. We were still in that learning curve, later part of the learning curve. And we really hadn't incorporated the fellows into it. And Dr. Hogue was one of the fellows on my service. Dr. Zerkat had a medical problem and he had to go out. And I told everybody, all right, we're going to shut down the robotic Whipple program for a while. And she convinced me, no, give me a chance. Let me get in there and see what I can do. And I said, all right, we'll give you a chance. And I sat her down at the console for her first robotic distal, and then the next day robotic Whipple. And she was like a savant. It was, she was able to do, instead of yelling at her, clutch this, grab here, trying to teach her the robot and the operation at the same time, I was able to teach the nuances and say, why don't you go over here and do this? And she was able to control the robot. And I asked her after the case, how is that? Were you just born to do robotics? Did you play a lot of video games? How were you able to do something that none of the fellows and most of the attendings weren't able to do? And she said, well, I just spent time on the simulator. I was like, simulator? I never even heard of a simulator. Turns out that Intuitive had developed virtual reality simulators to help people master the console. And she had spent a lot of time prepping for her time on service on this simulator. So she showed up at the OR with mastery of the console and was able to learn the operation. You contrast that to my learning curve for the Whipple. I went to Hackensack. Intuitive wouldn't let me go unless I posted my first case. So I posted a Whipple. I went to Hackensack for 8 hours. I operated on a pig. I think we did a cholecystectomy and a ureterostomy. I went back to Pittsburgh, and my first robotic Whipple was proctored by a gynecologist. And that was the learning curve. That's the only thing we knew at that time. Of course, it took 10 hours. We didn't convert, but this is where the field had come, and Dr. Hogue had that insight. And this is really where we said, okay, this is something that we need to focus on, and we're obviously going to need to go back and figure out how to minimize these learning curves in the ORs, because these are really insurmountable. 80 Whipples to master this is not going to work. That's where the second bit of serendipity comes in. Fields of observation, chance favors the prepared mind. That's when this paper came out in the New England Journal of Medicine, and I'm sure many in this audience know about John Birkmeyer's work, where he had been assessing outcomes of bariatric bypass in the state of Michigan for many years. They had looked at all the sort of quality measures, whether you got your heparin, your skip measures, and then somebody in their group got the bright idea that maybe what was making a difference in the patient outcomes, what was going on in the operating room. So they came up with this idea of having all these 200 surgeons they were working with give a 15-minute video clip, their NFL highlights. It wasn't random. It was, give us your best gastrojejunostomy. And then they had a subset of that 200 grade them. And the reason it got into the New England Journal of Medicine is, sure enough, if your peers scored your surgical skills in the top quartile, the chances that your patient would have any complication, surgical complication, medical complication, reoperation, readmission, emergency heart visit, they were all improved. And so all of us can walk into an operating room and in 5 minutes know if a surgeon is a good surgeon or a bad surgeon. We've known that for years. But what Dr. Birkmeyer was able to do is really take it to the next level. He assigned a number to it. So you could get a score on this OSAT scale, and that score correlated to how the patient was going to do. So this was something that was pretty intriguing. So the first thing we did, one of the other nice things about robotics is every case is videotaped. So we had a lot of videotapes. So we had Dr. Hogue going through and look at all our first 150 pancreatic jejunostomies, and we had two blinded observers do the same thing that Birkmeyer did and grade us on the pancreatic jejunostomy. And sure enough, just like Birkmeyer showed, we were able to show that if those two blinded observers scored us as being technically better on a modified OSATs on that day, that the patient was less likely to have a postoperative pancreatic fistula. Now, there were couple of major differences between Birkmeyer and ours. He was looking at 200 surgeons with very heterogeneous skills, and so the scores were quite different. Not surprising you'd see difference in outcomes. What surprised me is we were only looking at about 4 surgeons at that point who sewed all 150 of these, but it said on a given day, our performance actually made a difference. And so we can talk a little bit about that later in the talk, but that was pretty impressive. The other thing that was interesting is that we were able to drive down on this and really show that the whole anastomosis didn't actually make a difference. We graded OSATs, but we also, Dr. Hoag came up with what we called the Pittsburgh pancreas scoring, and she graded every single stitch on a scale of 1 to 5. And it turns out that the only stitches that made a difference were the posterior duct to mucosal. So that was interesting, but what it allowed us to do is really think about when we're training people, and I'll show you in a minute the simulation that she came up with. We could tell them really focus on these 2 stitches, deliberately practice this because this is what's going to make a difference to the patient. And we had data to support that. We went through all of the anastomosis so that we had a big video library, and so we've been able to extend this from the PJ. Dr. Zerkat, after I left, was able to look at the HJ and show that the distance from the hilar plate, so really dissecting the anastomosis using video review, that the distance from the hilar plate correlated to postoperative cholangitis and biliary stricture. The group in the Netherlands who we mentored through Dr. Hoag's curriculum, which I'll go through here in a minute, was able to show the same thing that she showed for the GJ, that the HJ scoring made a difference when it came to bile leak. And the GJ, we were able to go through and look at that by video review and show that the length of the gastrojejunectomy when we assessed it and the angle with which the anastomosis sat made a difference to delayed gastric emptying. So all of this was made possible through this sort of, I think, paradigm shifting paper that Dr. Birkmeyer published saying, hey, look, what's going on in the operating room is making a difference to the patients. And if you take the time and pay attention to it and you go through and you score it and you see what you're doing, it can start to make a difference to how the patients are doing. Of course, this has been shown in other fields. Theodore Grant-Cheroff, who is the founder of the Black Box, which I'll mention here in a little bit. He was able to show the same thing for robotic prostatectomy. They used a different scoring system, gears, but they showed that the incidence of bladder neck leak and impotency was directly correlated to the surgeon's score. And then Carbo Moria was able to show for laparoscopic cholecystectomy very similar things in this JAMA paper. There, they were able to actually kind of really narrow it down and say for every point in the surgeon's technical skills that improved, there was a 3% less complication rate. So that's really getting granular. But it says, again, that what we do in the OR makes a difference. We can assess it by video review, and it makes a difference to the patient. So let me get to Dr. Hoag's curriculum briefly. Really it was all based on simulation. We didn't want surgeons to have 80 cases of their learning curve in the operating room. And so really, the no see one, do one, teach one anymore. We wanted surgeons who were going to be doing robotic Whipples to show up with some preparation. So she came up with this video reviews-based surgical training, which I would argue is applicable to all surgical training, not just robotics. And it starts with mastery of the console. And that's really in the robotics where we do it with virtual reality. For the robot, it's a little different. You have to overcome the lack of haptic feedback. So she came up with an inanimate curriculum where you're doing deliberate practice of the anastomosis, where you're really teaching your mind to feel with your eyes. And then the video library where trainees and other surgeons can go through and look at 50 uncinate dissections in every variation so that they can really start to learn what's going on, as well as those papers I mentioned where we were able to go through and dissect which technical factors made a difference in the patient outcome. Of course, integration into the operating room as part of the fellowship and decision-making is super important, but this was really focused on the early technical skills. So an example of how a surgeon might move through for needle tip control in order to sew the pancreas anastomosis to get that duct to mucosal suture without tearing it and ending up with a fistula. The trainees would start in virtual reality. Lots of great feedback. You know right away if your needle tip control, as Dr. Yo used to say, needle tip control. I didn't have it back then, but I got this with the VR. Then you move to inanimate world where you can throw needles in a sponge. Make sure you don't tear the sponge. But Dr. Hoag Hogue recognized that adult learners, and she got her master's in education during her time as a fellow and junior attending with us, and really thought, that adult learners are going to get bored just throwing sutures into a foam mat. So she came up with these artificial biotissue drills. And the idea, again, was to simulate exactly, just like an airline pilot in a flight simulator, exactly what the surgeon was going to be doing in the operating room. And we didn't have them just go in there and practice it blindly. We actually videotaped every single one of these, and they would get a score on every single one of these. So they knew when they were improving, and it was deliberate practice so that they'd be ready to sew in the operating room, but when the time came. I won't go through. There's an enormous amount of literature that Dr. Hogue's been able to generate about this, but this most recent paper, I think, is sort of something I've been pushing the team to come up with for a long time, which is really start to correlate the scores in simulation to what's going on in the patient. And we were able to just recently do this paper where we took a lot of the surgical residents at UT Southwestern who were going through this curriculum. We took their scores on the gastrojejunostomy simulator, on the artificial anastomosis. And then we looked at their intraoperative OSATs and the difference in the delayed gastric emptying. And we're able to now come up with a score in simulation that correlates to the DGE rate. So this year, last 2 years now, we crossed a paradigm with this curriculum at UT Southwestern. We have the largest surgical training program in the country. For the last 2 years, every single one of our chief residents has finished a robotic Whipple from the console, but they don't get to sit down at the console until they show us their scores in simulation aren't going to affect what the patient is experiencing. And so this is really, I think, a final paradigm shift. Of course, Dr. Hogue's data was able to show that this did decrease the learning curve. So she looked first at just our group at UPMC and was able to show that Dr. Mosier and I's learning curve, which was quite long and protracted, was much better in the second generation of surgeons we trained at UPMC and in the third generations that we trained there. And then most recently, Mark Besselink, after the failure of the LELAPS and a lot of discussion about whether we should be doing randomized trials at all in surgical technique, became very interested in doing a randomized trial in robotic pancreatectomy. I encouraged him to do it differently than the LELAPS and to really focus in on some technical aspects and make sure when they did go to the randomized trial that they could assure that their surgeons were all past the proficiency standpoint. So he had Dr. Hogue and Dr. Zerkat and myself really had to sacrifice over a course of about 2 years, go over to the Netherlands, walk them all through this curriculum, score hours and hours of video in their simulation drills. But eventually, we were able to really show that we were able to get their surgeons' learning curve quite a bit less. Down to, for the distal, down to, the first portion of the robotic learning curve was only down to about 15 cases, and then it slowly petered out at about 40 cases, but much, much better than the 80 cases that we had encountered in the first generation doing this. And in terms of our overall goal, did we do anything to mitigate the effects? This is a paper that Alessandro Panicio at UPMC put together where he looked at the effect of the robotic approach on mitigating complications in our UPMC database. And in fact, he was able to show that there were less complications. And in fact, the overall survival, mostly because they got onto their chemotherapy, was was greater after the robotic Whipple, that complication rate was slightly less, and that the patients got more chemotherapy. And of course, Mark, many thanks to Mark for allowing me to present this. It hasn't been published yet, but the Diploma 2 trial, which they're now reporting, which was a randomized trial of robotic versus open pancreatic duodenectomy. The first primary outcome was non-inferiority, and the two approaches were equivalent. In their secondary outcomes, which was a composite time to recovery, there was a statistical advantage to the robotic Whipple in terms of recovery, decreased length of stay with no difference in readmission. So very pleasing after all these years to see that there's some data now that's come out supporting that we are seeing less complications. Patients are getting on to chemotherapy, and in a randomized trial where all the surgeons were trained to proficiency. I'll point out that I know there's another trial out of Germany that had an adverse effect, but their conversion rate was as high as our early learning curve. And again, I think that's because there wasn't a lot of time spent thinking about proficiency and who the surgeons were doing this. And hats off to Mark. It took a long time, 2-3 years of training. But I think this is a good outcome, and this trial was very well done. But what about that part of looking where the puck is going? And that's another aspect of the robotics that's pretty cool, because we get videotape from all of this, and we're able to now start really using AI for surgical assessment of surgical performance. So where are we sort of applying that now? Well, the first thing, if you have to have a person grade every single one of these videos, that's very workforce intensive. I can tell you, at Pittsburgh and at UT Southwestern employ an army of research associates to score all these videos. And so the first step was, can we train AI to do the same thing? And so this is, let's see if this plays. This is one of the early models where we're comparing the human graders from Dr. Hoag's database to our AI software. And already, in this very early model, the AI is able to do it with increased accuracy. And so this is where the future is going. One of the problems with this early model and most AI models is it sometimes doesn't explain why this anastomosis is not going to leak. It's not. We're now retraining the model to specifically look at the gestures that the surgeon is doing, because this early model was able to predict with better accuracy whether it would leak, but it wasn't all that explainable because it didn't tell us what it was looking at. It could have been the soft pancreas. The computer might have been picking up on that. So we're very hopeful with this, and we're continuing to work on this, but this is, I think, where the puck is going. I wouldn't be surprised if in the next 10 years, all of us would have video being evaluated by AI in our surgical skills. Pilots certainly have to be evaluated by computers in their simulation. We're actually also, with the help of a fourth-year resident at Pittsburgh with a similar name, looking to see whether the computer AI software can really start to help us with the oncologic outcomes. And so this is the first iteration of this model, which is deep learning recognizing margins. So we have these 200, 300 robotic Whipples where we've done vein resections, and we're basically now asking the AI software to tell the surgeon, is this going to be a positive margin? Do you need to take more? And again, early on in these models, pretty impressive areas under the curve, receiver operating curves for this AI model. And really, where is this going? It's one thing to score a surgeon, to know whether your margins are going to be positive 7 days or 30 days later. Where all this is going is over the shoulder, right? So all these computing power now, once we develop these algorithms, we can start to plug these right into the intuitive and whatever robotic platform you want to. So the idea is that these models that are scoring your performance, that are telling you whether or not there might be a positive margin, will be watching you operate, and will have, different warning lights. I never imagine a day where it'll take over, but it'll at least be able to give you some warnings. There's wind shear ahead. Looks like the right engine's not doing so well, and give us some warning. And so that's where we're heading with that. And that's really also where Theodore Grancharoff deserves a lot of credit, because he's had since his early days looking at robotic prostatectomy and technical skills, he had the genius to recognize that there was a lot going on in the operating room that wasn't just the surgeon's technical performance. And in fact, the difference between Dr. Berkmeyer and our paper in Pittsburgh, Dr. Hoag's paper, with 200 surgeons versus 4 surgeons, why was the performance different in a group of proficient surgeons? He would suggest it's because there's a whole lot going on in the operating room around the surgeon. And if you don't measure that, you're only going to get to one part of the puzzle. And so he's championed and came up with this idea of the OR black box, which we've put into place at UT Southwestern, initially with a pilot project just in our robotic operating rooms for 3 years. And then as of March of last year, we went expansion. Every one of our 40 operating rooms have a OR black box. And it's really just a comprehensive data collection tool. So it does record the video feed from the minimally invasive. It has video cameras over anesthesia, over the instrument tray, and it has all the patient vitals all into a single database, which you can mine. And we've been able to show a couple of papers early on showing that team performance, which is the OR black box, measures not just the surgeon's technical performance, but also the entire team. And we are able to show over a course of about 3,000 cases that how the team performed in their checklist, specifically the debrief at the end of the case, seemed to correlate with length of stay, mortality, and ICU stay. And Andrew Bain, one of our residents who's getting his fellowship in medical informatics, has now started to take the data off the black box that the AI software flags this case as being out of normal, whether it was a prolonged hypotension, hypothermia, or hypoxia. And we're developing predictive analytics for things like surgical site infections, length of stay, and readmission. And we've been able to show, on top of all the variables that the NSQIP calculator does, what actually happened in the operating room augments these models and makes the area under the curve. And again, the same idea, we're hoping in the next year that this report from the OR black box will be able to tell the surgeon that this is your specific patient's risk of wound infection based on their preoperative variables and what just happened in the operating room, and provide that information back to the surgeon so they can make a real-time decision about what they might want to do with the postoperative care. And so we're pretty excited about that. And I think someplace, again, where the puck is going and not where it is. So I'll kind of conclude. Obviously, I started my career on the shoulders of giants, and Dr. Cameron's legacy is incredible. But we are starting to build a little bit of a legacy around MIS. This was a paper that was published not too long ago, looking at all the MIS pancreaticoduodenectomy literature, and you can see that I think focusing on dissemination as our main goal seemed to pay off. And Dr. Zurikat, Dr. Hoag, and Dr. Zanati, who is actually our statistician, are sort of the top four cited authors in this field. So I'll stop there, and I want to thank again the Society and Taylor. An incredible opportunity to give this talk, and thank you all for your time.